Well, hello again, class. We're also going to be discussing this week Chapter 12, which is going to discuss juvenile treatment. So, our learning objectives for this lesson are that by the end, you should be able to summarize the different viewpoints concerning treatment in juvenile justice, describe the different treatment modalities that are most frequently used in the juvenile justice system, evaluate those treatment modalities, and identify suggestions for improving treatment options that are available in juvenile justice agencies. So let's look at where treatment began. Well, in the 1950s and 1960s, sociology dominated the treatment efforts. So they looked at pre-delinquency community programs, using detached workers, so those were like social workers or volunteers, using group interaction, job training, and community reorganization to address delinquency. So there's been 4 correctional treatment stages throughout the years. We started in the 1920s through 1960s with rehabilitation is not appropriate. We don't want to look at rehabilitation. We then go into the nothing works era. So why are we even trying? No treatment works. Then in the late 1970s, from the early 1970s to the late 1970s, we started saying, well, some treatments do work, to the late 1970s and in through today, that there are numerous programs and innovations that can work to treat our juvenile offenders. So we're going to go through each of these stages briefly. We're starting with rehabilitation isn't appropriate. So during this era, the medical model was discredited, and this model said that with given proper treatment and care, criminals can be cured of their criminal offending or juveniles of their delinquent offending. This model suggested, however, that people were committing crimes for reasons that were outside of their control, things like poverty, racism, and injustice. But this discounts the personal responsibility that people must take for the crimes that they commit. So critics argued that rehabilitation's assumptions conflicted with basic human values. They also said that the rehabilitation philosophy simply didn't work, that you could not rehabilitate a person. That in practice, rehabilitation was actually a disaster. But I think the reason that they looked at rehabilitation as being not effective in such a huge way is because we were looking to cure criminals. There's no cure for criminality. There's not some one treatment fits all. You have to use a couple different types of treatment. And there's no curing delinquency, no curing criminal behavior. What you're doing is addressing the behaviors, you're addressing the risks and the needs of that individual to improve their situation and their thinking patterns so that they can make proper choices moving forward. So in that way, we're not curing criminality, we're addressing the person, which is how we look at rehabilitation today. So this takes us into the nothing works stage. So the late Robert Martinson said, in general, rehabilitative efforts had no appreciable effects on recidivism. He also said there was no evidence that correctional rehabilitation was reducing recidivism, and the media took off with this. So we know how the media can, and the way things are portrayed in the media can have huge effects on justice policies, and the way the public views justice and criminal as well as delinquent behavior. So the media took off with this and people just believed it and assumed, well, there's nothing we can do at all for these offenders, so we might as well just lock them up. We're not going to bother wasting our money and our time and our effort on treatment if rehabilitation isn't working. However, a lot of the other researchers that had agreed with him recanted in the late 1970s to say that, well, there are some treatments that are working. So Ted Palmer, who was a correctional researcher, said that programs are going to work best when they're new, when the subjects themselves are amenable to treatment, so meaning that they can be treated and they can be improved through treatment, when counselors are trained, well trained, but also when they're just good people You want to have people that have good moral standing delivering these treatment programs. Additionally, they said that 86% of intervention programs that were studied reported success. So I don't know about you, but I would say that that's successful, that means treatment is working. Any percentage of improvement and success, I would say, is positive and in the right direction, is better than doing nothing at all. And then there was a meta-analysis that showed an average reduction in recidivism between 10 and 12%. Again, 10 and 12% is huge depending on what numbers you're looking at. So during the Some Treatments Work era, they also said that interventions with large effects in recidivism reduction are going to target high-risk offenders. They're also going to have offenders that complete the program fully, that do not drop out, and that, interestingly enough, coerced clients did as well as voluntary clients. So going back to the idea that someone doesn't have to voluntarily participate in a treatment program for it to be effective. And then the amount and quality of the program matters. It matters how much time, what we call it today is dosage and duration. Dosage, the amount of hours that the youth is getting in treatment, and duration, the number of weeks that they're involved in the program. So your book talks about Dr. Mark Lipsey, which he and Dr. Chapman actually created the SPEP process, the Standard Program Evaluation Protocol, and we can discuss that sometime for those who are interested. But I'm actually involved in the SPEP process with work, and what it does is evaluates programs for their effectiveness. It looks at what amount of dosage and duration, what's the quality of the program like? What are the types of youth that this program works best for? So it looks at all of this research that your book talks about and says, let's determine if this program is effective, but it doesn't stop there. The SPEP process then looks at, let's do a program improvement plan, and let's help the program to improve, because it's not enough to just say, your program's not working and it's not being successful. No. Let's get your program to where it needs to be. Let's get your staff trained. Let's make sure you have a manual so staff knows how they're to deliver the program. Let's make sure it's being supervised by a supervisor who can monitor those staff and then give feedback on how well they're delivering the program. All of these components come together to make sure that we have effective treatments being given to our youthful offenders. So now getting into our numerous programs work area, which is where we are today, and as evidenced by the SPEP process that I just spoke about. So during this era, we use risk needs assessments, which attempt to offer treatment relevant information when residents are classified into a new facility. So that's what these assessments do. We also want to focus on the responsivity principle. So this says that programs should consider an offender's situation and individual characteristics that could possibly be a barrier to them being successful in the program. For instance, say you have a youth who the family does not have their own transportation. They rely on public transportation. We don't want to put that youth in a treatment program that's located in the next city over, where it's going to be very difficult for them to get to treatment. We also want to look at the juvenile's own personal abilities and characteristics. Say they have a learning disability, or a developmental delay, or a mental health issue. We want to be careful as to which programs we put them into, that they're going to be able to understand the concepts that are being taught. And then the best practice principle, which is what we use today, it simply says that programs should be based on previous research that shows proven successful programs. That's it. The programming we use today should be based on previous research and proven successful programs. Let's use what we know works, so best practice. And then what are some principles for working with serious offenders? Well, for one, programs with multiple modalities must be used. Again, you can't use just one treatment modality and expect that that is going to work for every offender. The intensity of contact needs to be increased if we're going to have effective programming. Because again, these are high-risk offenders. We want to make sure that they're having, which we talked about in Chapter 11, that staff interaction. We want to increase the interaction between staff and offenders. And then greater attention needs to be paid to the offender's needs and characteristics. Again, look at the individual. It's not a one-size-fits-all. So how do we classify youthful offenders? So for one, we have the Youth Level of Service Case Management Inventory, or the YLS CMI. So this is based on three things. The risk principle, which says that services should reflect the level of risk that an offender presents with. The need principle, which says services should be matched to the delinquent needs of youth. And I'll go one step further and add in there the criminogenic needs, those that are specifically related to criminal offending, and the idea of responsivity that we just covered. So interventions should consider a youth's circumstances as well as their individual characteristics. We also have the Youth Assessment and Screening Instrument, or the YSAI, and this is a method for placing youth into categories corresponding to the likelihood that they're going to have future arrests or engage in future violent offenses. So this assesses risk, needs, as well as protective factors. So protective factors are those which are going to protect a youth from engaging in delinquent behavior or protect them from being exposed to situations that could lead them to engaging in delinquent behavior. These are things like being involved in therapy privately, playing sports, having positive pro-social peer groups, being involved in clubs, attending school, having a job. These are all things that are going to protect that youth from engaging in antisocial behaviors. And then I'll cover the Juvenile Risk Assessment tool. There's a number of we'll cover two more tools. There's more that are mentioned in your book, however. So the Juvenile Risk Assessment tool, or the JRAT, is an initial assessment for male juvenile sex offenders. So it's just going to assess the risk that male juvenile sex offenders present with. And then the Massachusetts Youth Screening Instrument, we're now on the second one. It's been revised. We use this in our county, and a lot of counties are starting to use this these days. So it's a self-report inventory. So youth take it alone, either on paper. In your book it says on paper. We do have youth that are now taking it on the computer. It's 52 yes or no questions for youth specifically between the ages of 12 and 17. You cannot give it to youth outside of that age range because that's what empirical research says. This assessment the age range that it can assess. And the goal of it is to identify mental health needs for that youth. So it quickly identifies and screens when youth come in to intake. So when we have a youth that initially comes into our probation department and the petition comes through, we give them this assessment during intake to quickly identify, are there any mental health needs here or any serious needs that we need to begin addressing before we even bother looking at their petition. Of course, they're going to go through the court process in the way that policy says they need to, but let's make sure that we're addressing those mental health needs first and foremost. So risk assessment instruments also assist in case planning for youth and determining which services and treatment are going to be best. So let's look at some different treatment modalities. So we have individual level treatment programs and group programs. The types of individual include insight-based therapy, behavioral therapy, and cognitive behavioral therapy. Groups include things such as guided group interaction, positive peer culture, as well as drug and alcohol abuse interventions. So let's look at some individual treatment modalities. So insight-based therapy utilizes insight, persuasion, suggestion, reassurance, and instruction to get residents to see themselves and their problems in a realistic fashion. So it talks about past conflicts that resulted in aggressive or antisocial behavior and helps to resolve that conflict and unconscious need that drove the individual to crime in the first place. In this way, youth now become responsible for their own behavior. So examples of insight-based therapy include psychotherapy, which examines individual problems with a psychiatrist, psychologist, or a social worker. You can have transactional analysis, which will examine individual problems in a group context and learn new approaches to interpersonal relationships. So, transactional, having a relationship interpersonally with another individual. And then reality therapy, which helps individuals learn to cope with reality. They'll model responsible behavior and help the individual to determine right from wrong. A lot of youth sometimes don't even know in the situation what the right or wrong answer is. We do skill building with youth as probation officers, and sometimes they're things as simple as having a difficult conversation. I'll use the example of youth taking a class. They have an assignment that they don't understand how to do. Rather than going and asking that professor or teacher how to do the assignment, they just might not do it. And when confronted about it by the teacher, why didn't you turn this assignment in? They might get angry. They might yell at the professor and say, it was a stupid assignment, I don't care, I didn't want to do it anyway. So our job is to teach them how to handle that situation. One, they should have went to the teacher beforehand and said, I don't understand this, could you explain it to me? Two, when the teacher confronted them, they should have handled that situation better. They could have said, teacher, I didn't understand the assignment and that's why I didn't do it. But youth aren't able to express themselves sometimes in that way because they're not used to it. So these individual treatment modalities get them to take responsibility for their own actions and behavior and helps them to see their problems realistically so that they can address situations in a more positive pro-social manner. So, behavior therapy is another type of individual treatment modality. Behavior therapy utilizes positive reinforcement to encourage desirable behavior and negative reinforcement to extinguish undesirable behavior. So essentially, we want to encourage the good behavior they're doing and discourage the bad negative behavior. So then we get into cognitive behavioral therapy, which utilizes training approaches to teach new skills in areas where offenders show deficits. So just as I was explaining, the goal here is to identify cognitive deficits that are specifically linked to delinquency. So the example I shared, say that offender is now being verbally aggressive towards their teacher. They're not respecting authority. Those are things that we assess for on the YLS CMI instrument that is going to lead to delinquent behaviors. They also target thoughts, choices, attitudes, and meaning systems that youth holds that are associated with antisocial behavior. Cognitive behavioral therapy follows a structured curriculum and uses rehearsal of skills, assigning homework for the youth to practice those skills, and intensive feedback for behavior change. So cognitive behavior therapy assumes that the foundations for criminal behavior are dysfunctional patterns of thinking. It says that they're more effective in reducing recidivism than simply behavior programs. So cognitive behavior therapy, we're looking at the cognitions of the youth. So what are their thoughts and how do those thoughts lead to their behavior or their actions? So you're addressing both the cognitive and the behavioral part of delinquency. So CBT is actually a critical aspect in effective correctional treatment. This is used in numerous types of treatments for youth these days because we know that it works. So what are some group programs that we have? Well, GGI, or Guided Group Interaction, is the most widely used treatment modality for groups. So GGI is based on an assumption that youths can confront their peers and force them to face reality or the reality of their behaviors more effectively than staff ever could, because those youth understand what the other youth is going through. So this uses a non-authoritarian atmosphere, intensity of interaction, group homogeneity, and an emphasis on group structure. So it attempts to move group participants toward a more positive pro-social stance than their negative cognitions they'd been thinking in. So the responsibility here really rests with the offenders in the group to encourage one another. There's no clear, consistent philosophy here, though, that guides the process, so it can take many forms. And it does tend to have a more positive impact on less delinquent youth, because initially you assume that to have these peers be able to get one another to see what they're doing wrong, you have to have a peer in that group that identifies what's being done wrong in the first place. So then our PPCs. So this is a system for building positive youth subcultures. So this grew out of GGI and is characterized by trust and openness. It focuses on direct and immediate problems. This includes youth that are similar in age, sex, maturity, and you want to make sure that they're also similar in their type of delinquency and the sophistication of delinquency that they engage in. So the main philosophy here is to turn negative peer culture into a positive one and mobilize the power of the peer group. So the recommendations are going to initially come from group members, similar to how GGI works. Teaches group members to care for one another. So a big part of this program is just simply caring about one another enough as peers and as individuals to want to see them do better. And then finally, we'll address drug and alcohol abuse interventions. So institutionalized juveniles are typically placed in separate cottages or floors if they're going to engage in drug and alcohol abuse interventions. Institutional social workers or staff will typically conduct the drug and alcohol groups, or you can have outside groups such as NA, Narcotics Anonymous, or AA, Alcoholics Anonymous, come into the institution and they'll hold groups with the offenders. So the success of these are that it reduces relapse, they reduce criminality, reduce inmate misconduct, reduce mental illness, as well as reduce behavioral disorders. They increase the level of inmate stake in social norms, increases the level of education and employment that the individual has when they return to the community. They improve health and mental health symptoms and conditions, because we know that drugs and alcohol have a huge negative impact on our internal bodily functions, and it can help to improve relationships for that youth. So let's look at treatment effectiveness. So what are some issues with treatment programs? Well, designs are giving little consideration to what can realistically be accomplished with youth in the certain setting that they're in. They're typically also relying on a single cure for a variety of complex problems. Again, we need different treatment modalities to address the complex problems that youth present with. Some treatment programs lack integrity. There's also inadequate research on offenders' rehabilitation and what works, which programs are reducing recidivism and are rehabilitating these offenders. So what are some steps that we can take to improve the effectiveness of treatment programs? Well, including ingredients of effective interventions, having these programs be based on better program design to ensure higher program integrity, and also having them be evaluated more rigorously so that we know through research whether they're working. Research also must provide us information on what works, so what programs are working and what aspects of the programs are working, for whom do they work best, and in what context or in what setting. So a few ingredients of effective programs. Well, they're set up by an inspired individual or group, so this person is dedicated to setting up a treatment program. They have developed a unified team approach, so all staff members here are going to become treatment agents. They're going to help develop short and long-term goals for the program. They have a transmittable philosophy of life, so they're going to be able to generate a sense of mission or purpose among the offenders that's going to help them learn the program well enough so that the offender can reintegrate that into their own life. They trust offenders with decision-making responsibilities. So more often, offenders are allowed to make choices that concern what happens to them, and they're going to be then more likely to be involved in the treatment program and benefit from it. They also help offenders develop needed skills. So they're going to help offenders learn new tasks with educational and vocational, as well as interpersonal relationships and problem solving. What else goes into an effective program? Well, they should be regarded as unique or different by the offenders. So components that make them different from other programs grab the attention of youth, so they want to engage in the program. They haven't heard about it before. They haven't been able to talk to all of their peers and their other delinquent friends that say, oh, that program was dumb, that didn't do anything for me. And finally, they provide an integrated treatment model. So they utilize not only screening, but assessment tools. They use case planning, different treatments, transitions from aftercare across all parts of the juvenile justice system, including core treatment programs, looking at different work, education, mental health, and even recreational programs. So what are some strategies that we can use to improve the effectiveness of correctional programs? So the strategies are going to be 1, program design. So this says that theoretical constructs of the program must be 1, examined to determine whether they're appropriate for a particular group of offenders, and do they mesh well with the treatment setting. And then we need to examine the process by which these interventions are actually changing antisocial behavior. Looking at program implementation, offenders need to be placed in the right program and at the right time for them to benefit from treatment. We need services that deliver what they claim to deliver, with the strength to accomplish the treatment goals that they set out to accomplish. Treatment staff also need to have sufficient training and adequate supervision by those above them to make sure that they're delivering the program properly and it's being implemented to fidelity. Then we have program evaluation. So simply looking at, is the sample size large enough when we're evaluating this program to properly measure an effect size? Whenever possible, we should use true randomized experiments because they're the most rigorous. And we should identify common elements of effective programs to determine how these elements can affect success with particular groups of offenders. So again, making sure we're matching the proper treatment to the proper groups and types of offenders. So what does work? Well, Palmer's approach looks at skill deficits. So skill deficits should have developmental challenges in areas of life and social skills. They should address external pressures and disadvantages, which are major environmental pressures and or major social disadvantages. And address internal difficulties. So these are long-standing or situational feelings, attitudes, and defenses that the individual holds, as well as addressing ambivalence to change, and an individual's motivation, desires, and personal commitments to being productive and being successful within the program. So, in sum, there are 4 viewpoints to juvenile justice treatment. The first is that it says rehabilitation doesn't work. The second stage or era we went into was nothing works. Then we went into some treatments are going to work, to where we are now, that there's numerous programs and innovations for treatment that work with juvenile offenders. So both individual and group treatment modalities are used in the juvenile justice system. Long-term training schools are the least promising place for treatment to occur, but through research and evidence of best practices within treatment, we can improve the positive outcomes that youth have and lower their recidivism rates. The future effectiveness of juvenile justice treatment is contingent on having funding research for development of more effective technologies, identifying what works for which groups of offenders, and creating more humane environments where offenders are being treated with dignity and respect, and we're giving them some responsibility in the treatment. So that was your Chapter 12 lesson on treatment programs in the juvenile justice system.